Hi everyone, this is Megan, the dietitian. Can people hear me? Hi everyone, welcome to the webinar. My name is Megan Foley. I am the lead dietitian at the ACUTE Center for Eating Disorders at Denver Health Medical Center in Denver, Colorado. Today I'm just going to talk to you all a little bit about the nutrition rehabilitation and early refeeding of severely malnourished patients. This is a follow-up webinar to the webinar Dr. Margarita Moscolo provided last month talking about gastrointestinal complications. So we're going to talk about that and how refeeding patients can help with that. So just a quick recap of what was discussed last month by Dr. Moscolo. She discussed the gastrointestinal complications of severe malnutrition. So she talked about things like dysphagia, GERD, constipation. She helped to differentiate between organic etiologies of GI symptoms and psychologic etiologies. So helping a patient to understand, are you really constipated and how can we help you versus are you somatically constipated and can we show you a scan to say that actually everything's going really well. And she also helped to discuss different treatment options from a medical standpoint with medications and such to help discuss those things. So this is going to be focused a little bit more on the nutrition aspect of this. I think this is such an important topic because so many people are affected by eating disorders. They have the highest mortality rate of any psychiatric diagnosis. So really helping to come together and address these medical complications from a nutrition standpoint and a medical standpoint are so key in helping our patients to heal and survive. So the objectives of this talk are going to be to help understand the role of the dietitian in the refeeding process and how, again, the nutrition can affect these people versus just the medications they receive, to understand how to nourish our patients based off of their medical complications, and to discuss some of the pros and cons of using enteral nutrition and parenteral nutrition in this severely malnourished population. So a little bit about what we do here on ACUTE and just how it might differ from other providers that are listening in or other dietitians. Just a little bit of the philosophy of the nutrition therapy at ACUTE. So typically on ACUTE, our patients are below 70% of their ideal body weight. I believe the lowest patient I personally treated was 46% of her ideal body weight, but typically they come in the high 50th percentile to low 60th percentile. They all have some sort of eating disorder behavior, so this can include significant restriction, purging, laxative abuse, ARFID, so if they're afraid of eating for some reason and it's not really about body image, or a combination of those things paired with orthorexia, which can make the refeeding process a lot more challenging. And almost all of them are medically compromised. So they can have organs that are severely compromised, heart rate abnormalities, electrolyte disturbances. So those are kind of what we see here on ACUTE. Our main goal is to get them to a safe enough spot and a medically safe enough place to move on to other levels of care. So with that being said, we need to recognize with any state of a patient you're working with kind of where they're at in their process. So here, because they're so malnourished, we really want to just make our very first priority is nourishing them with nutrition. So sometimes that may mean all tube feeds, sometimes that might mean letting them eat the same food over and over again, but at the end of the day, we just want to give them nutrition. Obviously, as they advance, that needs to become a priority with variety and flexibility, but here, just nutrition is our main priority. Depending on the patient and where they're at, we really want to work on correcting their macronutrient and micronutrient deficiencies. So if they're coming in and avoiding all fats, really working on increasing fat in their diet, or if they're avoiding all carbs, working on giving them more grains. Helping them to empower them to choose for themselves. So something I think is really important to recognize with eating disorders is that they're so punishing that making a choice can feel like a victory for their healthy self and not their eating disorder self. And so helping them to realize that that's a step towards recovery is really important. nutrition education if they're open to it, and then reducing disordered behaviors is kind of one of our last priorities, which is frustrating, I think, when they leave because they haven't worked a lot of stuff here sometimes. If they're going to cut their chicken into 80 pieces but still finish it, we're going to let them do that. We recognize that it's really important to be flexible and to work on reducing behaviors, but oftentimes they're so malnourished that they're just not in a space where they can work on those things at this level of care. So a registered dietitian's role in the refeeding process is obviously very important. So I just like to talk a little bit about what we do here to give everyone a better understanding. So on ACUTE, a dietitian's role involves meeting with the medical doctors and the patients 5 days a week. So we do round daily with our doctors to talk about the patient care. This can also include rounding with our psychologists and sometimes our physical therapists or social workers. If a patient's getting closer to discharge and they're on a feeding tube, it's important for us to recognize what we need to do to get them ready to go. So do they need to get off of the feeding tube? Do they need to be eating more than 5 foods? What can we do to help them reach those goals? We also assist them with menu planning. That's obviously our main goal, again, is nutrition. So helping them through the menu planning process is really important. We help to advance their diet to promote weight restoration. So at the end of the day, the main thing that's going to solve all these problems is some weight gain. So helping them make appropriate food choices, meeting their calorie needs, and incorporate challenging foods into their diet is something else we do. And then if they're on enteral or parenteral nutrition, we really are completely in charge of that as well. So increasing the rates, changing the macronutrients, et cetera. And something else I think is important to recognize from a dietary perspective is really instilling trust and promoting therapeutic relationships between the patient and the dietitian. I think sometimes dietitians get kind of pinned as, well, you're just in charge of giving them their nutrition. And so really understanding that we typically are the most anxiety-provoking part of their day, and that, they can trust us and we can help them to kind of work through things nutrition-related during their time here is really important. So initially, we really just want to work on building a rapport with our clients or our patients, and so that's obviously something all dietitians can do. We really want to set expectations. We're not going to mess around with them. We're taking their health incredibly seriously, and so we expect them to complete 100% of their meal plan. We expect them to gain weight. I think commonly we'll hear, I'm willing to gain 1 pound a week and that's it. But oftentimes our patients need to gain 20 or 30 pounds sometimes before they leave. And so if you're going to gain 1 pound a week, you might be here for 8 months before we can get you out of here. And so really setting the expectation that although weight gain might be a little scary, it's going to be appropriate, and that we're not going to mess around with their diet advancement either. If their body's showing us they need more nutrition or if they need to change in their nutrition, then we're going to do that, and that's our main priority. Really meeting a patient where they're at, I think, is such an important part of being a dietitian, and understanding their goals and expectations. I'm really willing to work on X, but I'm not willing to work on Y, and helping them to meet those goals. And then go over and just what we expect out of them and kind of meeting them where they are. We're understanding that you absolutely are not going to try a cookie while you're here, but we expect you then to try the next least scary thing or whatever it may be. We expect you to complete 100% of your calories. We expect you to continue with weight restoration, and really helping them to understand, again, that we're taking their health very, very seriously, and that we're going to work with them to kind of achieve a common goal. Nutrition-focused physical assessments are something else we provide in a hospital setting, and I think this can be done once you're trained to do in really any setting to assess where your patient is at. This really helps us to assess their progress and assess their level of malnutrition. It's been interesting to start incorporating this because, commonly we've been taught if a patient's under a certain percent of their ideal body weight, they're considered malnourished, but this has kind of evolved to look for different things. So now you're supposed to assess for muscle wasting, fat wasting, fluid accumulation, nutrient intake, weight loss, hand grip strength. And so a patient could come in at 65% of their ideal body weight, but if they haven't lost weight recently and they've been eating 100% of their calorie needs in the last month, they actually wouldn't be considered severely malnourished anymore. It can also help this to be a good learning factor for our patients if it's appropriate. Some patients come in and they realize, I look like a skeleton. And so helping them to see, look where your fat wasting is, your temporal wasting is like this, it should be like this. If they're motivated for recovery, that can help us to kind of find positive signs of nutrition. Understanding the therapeutic relationship between the dietitian and patient is really important for us. We really want to set these boundaries with our patients to know that, we're going to follow a certain protocol to help you get to a certain goal, but we are also going to try and be as flexible as possible to meet you where you are. It would be a lot easier for me to come in every day and say, this is what we're doing, period, no negotiation, but I don't think my patients would be quite as successful if that's what I did. And so really understanding where they're at and what they're willing to do and meeting them there really helps them to be actually more compliant during their time in treatment. Setting boundaries, though, is also really important so they know they can't take advantage of things. So I have 30 minutes today to help you with your menu. If you can't finish things in that amount of time, then I'm unfortunately going to have to pick stuff for you. We have to do a meal plan change, and that's not something we can negotiate. And then just setting guidelines on certain things to know they can't have 100 splendors every meal or whatever it may be, to help them understand, there is a role for the dietitian in their process. So meal planning is obviously a big part of what any dietitian is going to do and should obviously be done with the dietitian because the dietitians are going to be the experts in this. We really want to make sure we're setting a balance of structure and patient choice. So I will give you an option, but you get to choose between those options. Allowing them to have a say in what they're eating allows them to be more compliant with their meal plan and allows them to take charge of their recovery. If we just send them stuff, they won't complete, and eventually they might end up on a feeding tube, and it's just kind of this downward spiral. So really giving them as much opportunity as possible to have choices in what's happening, I think, is really empowering for them. We do provide pre-designed meals and limited choices, and I think this is really important in the sense of if you give them 10 choices, it's going to take them 10 hours to pick. And so, they're constantly asking themselves these questions. Does this have more calories than this? Or is this going to affect me differently than this is? And so really helping them to give those limited options is important. That being said, we can modify options as we think appropriate. So, if a patient is just terrified of eating something and that's one of the options, maybe we'll say, if you're really not ready to do a dessert yet, here's an appropriate substitution that's still going to provide you the same macronutrients, but in a less scary form. It allows them to work up to things that builds more rapport and trust, and it still continues to challenge them with nutrition. At ACUTE, we don't offer any vegan meal plans. We offer regular menus, gluten-free menus, and vegetarian menus. As far as the vegan thing goes, obviously, I'm sure we all know you can be healthy and be vegan. But if a patient is coming in to us at 60% of their ideal body weight and is strictly vegan, we try to send the message that, you haven't quite figured out how to do that yet. And long term, we think it's great if you want to meet with a dietitian who can help guide you through this process, but in this setting, it's just not appropriate. It can make discharge a lot harder, and oftentimes we find it's not an ethical thing, it's completely a restriction thing. And so really setting the message that there's room for all foods in their diet is important. We really try to avoid any specific allergies because commonly we see that they're not really allergic or intolerant to the things they claim to be. So recently we had a patient call and say she was allergic to soy, dairy, and gluten. And so I called to discuss this with her because we're not in a situation where we can accommodate all of those allergies. And upon further prompting and asking what kind of happened, she said, well, I get bloated or I get cramping or I get diarrhea when I have dairy and gluten. So, as a professional, I know that probably means you're just a little intolerant or you're just malnourished. We'll have patients come in that can't claim to not tolerate things. And then once they start to reintroduce them into their diet and gain some weight, they really start to see, wow, I can really tolerate these things. And so I think really sending that message is really, really important to our patients because they've convinced themselves they have to eliminate so many things from their diet, and it makes their process so much more challenging. This patient has since come in and she's eating dairy and she's eating gluten without any issues. If they do say they have lactose intolerance, again, we usually see that this is a reason to restrict something. So we really encourage the use of lactate pills and really just try to remind them that a sign of malnutrition is not being able to tolerate things as well. So as you continue to increase your nutrition and your weight, you will be able to have more flexibility with eating. We do see kind of a challenge with underfeeding versus overfeeding in this population, and so I think really being aware of that is important. If you have a patient who says, I was only eating 400 calories at home before I came here, you truly feel like you're torturing them by saying, well, we're going to give you an additional 1,000 calories a day on top of that. It's really, really physically and mentally tough for them. That being said, if you look at their resting energy expenditure, we'll see that it's usually somewhere around 900 calories per day, and that number changes drastically once they start to refeed, and they will need upwards of 3,000 or 4,000 calories to really get enough nutrition. Obviously, the amount of calories they need is going to be specifically related to your weight gain goals for your patient, and so daily weights are helpful if you can achieve them, but really kind of being aware of the fact that they are going to be hypermetabolic with their refeeding process is important. You don't want to start them too high because it can be really physically uncomfortable unless they're using some sort of enteral nutrition, but you don't want to start them too low because you don't want to start them losing weight due to the hypermetabolism that they're probably going to experience. And so, really just adjusting their calories based off of how their body is responding is really important. Nutrition education is something that I think is appropriate when patients are open to it. We really try to show them the positive effects nutrition can have on their body. So, fat is really important for these reasons. Protein is really important for these reasons. And helping them to understand that, the reason you're feeling better is because of nutrition. I just had a patient discharge, and she was saying how much pain her body was in every single day. And she was telling me how she couldn't even walk up the stairs anymore before she was coming to treatment. And this is really common, something that we see often. And by the time she left, she was doing pet therapy and walking the dog around the hospital. And so helping to understand the reason you can walk the dog and the dog can pull and you don't fall over is because of nutrition. The reason you're able to do your homework right now is because of nutrition. The reason your heart rate is normal is because of nutrition. And constantly reminding them that the reason these things are happening is 100% the nutrition they're giving themselves. And if they stop that, they're going to go right back to where they started with the pain and discomfort that they were having. Micronutrients are an important part of the refeeding process because obviously they might be deficient in some of these things based off of what they were eating before they came to treatment. So, if they're not eating any fat, they're not getting any other fat-soluble vitamins. So we do put all of our patients on multivitamins here. We do a thiamine repletion. Often they'll be on calcium or vitamin D because they're at risk for bone issues. And then if a patient's complaining of lack of taste or anything like that, we can start them on zinc. And then just as a side note, being aware of their medical history. If they have bariatric surgery of any form, kind of understanding what that looks like for them from a nutrition standpoint is really important. We do have bariatric dietitians here that we can consult and help us with that. But if you're in an outpatient setting or any other setting where you don't have that, just really understanding what they need to make sure they absorb all of their vitamins and nutrients is really important as well. So medical complications impacting nutritional care is the next thing I'd like to discuss. So typical issues we see here on ACUTE that we can use some nutrition to help with are hypoglycemia, refeeding syndrome, Pseudo-Bartter syndrome, gastroparesis, dysphagia, and SMA syndrome. So what I'd like to do is just kind of give you a brief description of each in case you missed Dr. Moskalo's talk, and then talk about how we use nutrition to help with all of these issues. So hypoglycemia is very common when our patients are underweight. Personally, if I'm hypoglycemic, I feel like I know. I'm hungry, I feel dizzy, I feel nauseous, I feel like I have to eat something right away. I think the scary thing about working with this population is because of their sometimes prolonged hypoglycemia, and that's what they're used to, they don't feel these physical signs and symptoms. And so their blood sugar can be incredibly low, and they won't even notice it. Therefore, they're not prompted to correct it. So a patient can come in and their blood sugars could be in the 30s and the 40s, and they're like, oh, well, I'm not sick because I don't feel anything about that. And so we really try to send the message that just because you're not feeling it doesn't mean it's not there. They can have seizures, they can have brain damage, they can have coma, they can die from this. And so really being on top of their hypoglycemia is incredibly important. If their blood sugar on ACUTE is less than 60 milligrams per deciliter, we will correct it, and our protocol is to use 4 ounces of juice or some oral nutrition supplement like Ensure or Boost to give them kind of a direct influx of carbohydrate or sugar to quickly increase their blood sugar. If they're refusing that, which can happen, we will encourage some sort of IV dextrose. The problem with giving them this nutrition is since it's not included in their calories, they have a really hard time accepting it. And again, because they're not feeling these physical signs or symptoms, they don't think they need to correct it. And so I think really drilling home the point that just because you don't feel it doesn't mean it's not dangerous is really important for them. Dextrose is an immediate solution, but what we see happens with dextrose is once you stop it, if they're not taking in enough nutrition, their blood sugar will tank. And so enteral nutrition is actually the preferred method if they're willing to take some sort of enteral nutrition. We make sure to check their blood sugar every 4 hours until it's normal, and this will normally happen with continued nutrition intake or calorie increases when they're able to start storing some glycogen in their liver. Usually this takes a few days, and their body needs to kind of get used to taking in that nutrition. So we do really encourage them having a nighttime snack, because otherwise they're going, I think, about 13 hours without eating, and then the blood sugar will drop in the middle of the night. So we really, really encourage the use of a nighttime snack to make sure that doesn't happen. Refeeding syndrome is something almost all of our patients are at risk for, but this is something that I think needs to be assessed for at any level of care, because there are so many different criteria that can put someone at risk for refeeding syndrome. So if you want more details, you can look up the the NICE guidelines, and they can give you specifics, but just some things that automatically put someone at risk is a BMI of less than 16. So almost all of our patients are at risk for this, but you might have a patient with a BMI of less than 18.5 that it hasn't eaten in, a week, and they could also be at risk. And so really understanding your patient's history, I think, is so important for this. So for us, weight loss less than 10% within greater than 10%, within 2 to 3 months, or those below 70% ideal body weight are going to be at risk. Any patient that's severely malnourished or underweight and has not eaten in 7 to 10 days are going to be at risk. So we automatically flag people for that. The main biochemical findings we will see are hypophosphatemia, hypomagnesemia, hypokalemia, glucose intolerance, fluid overload, and thiamine deficiency. So all pretty dangerous things. It's where you're working is really going to be based on how you should handle this. So Aspen is going to recommend about 15 to 20 calories per kilogram when you're starting to refeed someone. For a patient that's 30 kilograms, that could start them around 500 calories per kilogram. So that's very low. Obviously, if you have a higher weight patient that's at risk, their calorie intake could be a little more appropriate. But we have the ability here, at least, or in an inpatient setting, to start patients higher than Aspen recommends because of our protocols. So we check their labs every single day. They're on telemetry monitoring. We round with the docs every single day. We automatically start repleting their phosphorus, potassium, and sodium typically, because those are what we normally would see dropping. And, we're just really, really on top of it. If you don't have the ability to do this, you can't be as aggressive because you might not be fully aware of what their labs are doing. So on ACUTE, we can do that because we do have that ability. Pseudo-Bartter syndrome is something else we commonly see here, and it can be a really uncomfortable situation for our patients. This can be caused by self-induced vomiting or diuretic abuse. It's characterized by hypokalemia and metabolic alkalosis, and typically the patient's volume depleted and needs fluids restored via IV. So the patient's purging all of the time and they're really low volume, they can go into an emergency room and get their volume repleted, but they might gain about 20 pounds. And so it's incredibly challenging for our patients if it's not handled appropriately. It can cause a lot of physical and mental discomfort for our patients. Physically, if you gain 20 pounds of edema, your skin is like breaking at the seams. It's incredibly uncomfortable. And mentally, you go from cachectic looking to, one person described it as the Michelin Man. So a huge physical change that they see and can be very challenging for them to see. They automatically go home and start using behaviors. In a hospital setting, we can be very cautious with repleting their fluids, repleting them very, very slowly when they're rehydrating to help reduce that risk for the edema. And just, very cautious, being cautious with their dietary salt can help. Obviously, if they're retaining a lot of sodium and they're dehydrated, it can be really uncomfortable as well, but patients will typically be okay with this just because of, they don't want to do anything to make it any worse. Gastroparesis is something else that's very, very common in patients that are underweight and malnourished. It's not specifically related to eating disorders, but this is something we do see all of the time because our patients are all underweight. And this just refers to delayed emptying of the stomach. Typically, it's caused by weight loss, and symptoms can include early satiety, nausea, bloating, and reflux. I think it's really important to always listen to your patients and hear what they have to say about their physical symptoms. Sometimes I think it's easy to think, oh, they're being dramatic, or oh, they're overreacting to these things. But these are real serious signs of gastroparesis that can really lead to a stall in their refeeding process if they're having really serious symptoms. So really listening to them and helping them can be important. The medical nutrition therapy is a tough piece of this because we have to give them so much nutrition. So what normally we would tell someone to do is give them small, frequent meals, so starting with 5 to 6 meals a day, keeping them on a low-fiber diet with minimal fruits and vegetables, offering them a soft or liquid diet, so things like oral nutrition supplements, juices, or milks, and then offering them a low-fat diet. So these combination of factors can be really tough for a patient because they need a ton of calories sometimes. So when they first come in, we can offer them small, frequent meals. We can do a couple hundred calories 5 or 6 times a day and get them the nutrition that they need. But because of the rapid increase in their calories, this quickly changes to 500 to 600 calories a meal several times a day. So we just have to really be cognizant of what we're feeding them. The low fiber thing is something we really can control, and we really try to explain to our patients that because of the gastroparesis, your body is having a harder time digesting these fibers and is going to make you feel more full. We kind of try to tell them, you're taking up a lot of real estate without giving you a lot of bang for your buck. And so really trying to reduce the fiber in their diet is important. With this population, I'm sure we all see that this can be a challenging message to send, as they love fruits and vegetables because they can eat a lot of volume without getting a lot of calories. So really kind of helping them set boundaries with that is really, really important. The low-fat diet is something that can be challenging because oftentimes the higher fat options are the more calorie-dense options. So we can give them less volume, but we're giving them more fat. We do try to utilize this as often as possible, though, because we do find the reduced volume helps with the gastroparesis. So we'll use things such as whole fat milks, Bena-calorie. For those of you that don't know what Bena-calorie is, it's a fat that you can essentially mix in with things. So our 100-calorie mashed potatoes become 430-calorie mashed potatoes by using these. And so, when you can only eat a half a cup of mashed potatoes and get 400 calories, it's a really great tool to use. Liquids, those can be helpful as well. And medication. So this is kind of one of those instances where the medication and the nutrition therapy part really come together to make a really good team and really help with the gastroparesis. We try to remind our patients this is not a forever thing, this is a for now thing, and with weight gain, this is one of those symptoms that will resolve. So again, really driving home the point that nutrition is what's going to fix the problem that you're having. Dysphagia is something else we do see here. So with dysphagia, we see the weakened muscles that can cause difficulty swallowing, can obviously risk for aspiration and pneumonia and choking and other things. And so it's something we do need to be cautious of. I have found patients will use whatever excuse they can to not eat something. So I did recently have a patient tell me he was just unable to swallow anything, therefore he just couldn't eat. And so we do have the ability here to just consult a speech therapist and have come in and do a swallow eval, and then we can kind of have this concrete evidence to show you're actually totally fine, you can eat anything. But they're also great in the sense that if a patient's complaining and they're not okay, we have really good evidence to say this is the diet we need to use. So they can help them give swallowing exercises and recommend an appropriate diet. We can puree and chop their food. It's not the most fun diet to be on, but we can do that. And again, show them your nutrition is what's going to make this better and is what's going to get you out of this kind of crummy puree diet that you're on. We can also use appropriate supplements if we need to, so we can thicken their beverages if we need to lower their risk for aspiration. And we have Magic Cup available, so that's kind of a dysphagia nutrition supplement we can use. And then in really severe cases, we can use enteral nutrition. We do rely on the therapist to help give them swallowing exercises and appropriate clearing techniques, but again, giving them the nutrition is what's going to strengthen them and allow them to be more flexible with their diet. SMA syndrome is another thing we see here. I don't think this is as commonly seen throughout, but something that we do deal with and something to be very aware of, because your patient can give you symptoms that are going to kind of trigger you to think, okay, is this something they may be dealing with? So SMA syndrome stands for superior mesenteric artery syndrome. It is caused by weight loss. So it can be being extremely underweight, or it can happen to a person who's kind of underweight but lost a lot of weight in a short period of time. And what happens is they lose their fat pad that causes the superior mesenteric artery to compress the third portion of the duodenum. This can cause extreme pain when they're eating. It can be relieved immediately by nausea, by vomiting. Symptoms can be postprandial fullness, nausea, vomiting, abdominal pain, bloating. So if you have a patient that says, I eat and I immediately feel like someone's stabbing me, that can be kind of a trigger, like, oh, maybe this is something you're having. Or I feel a lot worse when I eat solids than when I drink liquids. Like I can get liquids without any problem, but I eat a solid and I'm in all this pain, or I have to throw up to feel better. These are all things that might tell you to say, I need to check for this SMA syndrome. So it can be scanned for with a CT scan, and then it can kind of tell you the severity of the syndrome and how closed their angle is. But sometimes if a patient's telling you that, you might just want to steer them more towards a liquid or soft food diet until those symptoms alleviate. If you don't have the ability to get them a scan right away, that might be something you can kind of recommend to them. So their type of diet is going to depend on the severity of the SMA syndrome. So again, if you do a scan, you can see, do they have partial or do they have complete, or do they not have it at all, obviously. If it's complete SMA, you might need to use some sort of feeding tube. But if it's just partial and pretty severe, you can usually get away with using a liquid diet. This is not a fun diet for patients to be on ACUTE, at least, because we are in a hospital setting and we only have so many options available that are liquid. So in an outpatient setting, you could potentially say, let's go to Jamba Juice and do smoothies and all these great things, but on ACUTE, we are limited with that. So it's typically things they're terrified of, like Ensure and chocolate, ice cream, and whole milk and things like that are going to give them a lot of calories, but in a liquid form. They have to be on this diet until they can tolerate more solids. So it really is kind of an advanced as tolerated situation. So if they're doing, well with the liquids and you've noticed that their weight's gone up 5 pounds, you could introduce some pureed food. If that's going well, you can advance them to some soft solids. If that's going well, then you can obviously advance them to a regular diet. If it's a really severe case and there's full SMA, sometimes they will need a J-tube placed past the SMA to still give them the nutrition until that fat pad comes back and that angle opens back up. And so, that's something to be aware of as well. And then, in more severe cases, you could use parenteral nutrition. If you can't pass the tube, you obviously don't want to put in a surgically placed tube. Parenteral nutrition can help them gain a little bit of weight in the meantime until that angle opens back up. Nutrition support on ACUTE is another important thing, and this can be important in any setting, inpatient, outpatient, whatever it may be, and it's something that we do need to use sometimes to help make sure our patients are receiving appropriate nutrition. So some indications for nutrition support are going to be discussed. The types of tubes we recommend using are going to be talked about. And then as far as parenteral nutrition, we can talk about some indications for that and when it's appropriate to use peripheral nutrition versus central nutrition. So some indications we've seen that might help say we need to use nutrition support are a history of multiple and unsuccessful attempts at diet treatment, a life-threatening weight loss of more than 40% below ideal body weight. So, if you have a patient who's 60% or 50% of their ideal body weight, they might be the most motivated person in the entire world, but if you need to give them 4,000 calories, it might just not be feasible for them to consume that many calories with how malnourished they are. If they're having a worsening or severe psychological or physical state, could be another indication. If you see your patient sit down 6 times a day to eat and they're crying every single time they have to put a bite of food into their mouth, is it really worth the psychological torture they might be going through to make sure that they are getting their nutrition? Complete non-compliance despite standard treatment. So this is something that needs to be kind of assessed from a psychological standpoint, a medical standpoint, and a nutrition standpoint. If they are in this level of care, they're usually so severe that we really can't waste, even 2 days without giving them nutrition. And so if they're kind of going day in, day out, not completing, not making progress, becoming more medically unstable, we can discuss whether or not it's appropriate to use an involuntary tube feeding. And this is kind of more going into the mental health laws here in Colorado, but it's an approach we do have to take at times. And same to go if they're completely unwilling or unable to cooperate with PO intake. So are they eating and then purging every single thing they eat? Are they just completely refusing all of their meals? These are all things we need to be cognizant of to make sure the patient is receiving all of the nutrition that they need. So when will we use enteral nutrition? So this can be really helpful for us in patients that have ARFID. If they are having this really terrible fear of choking, enteral nutrition can be really appropriate. So I had a patient who choked on peanut butter crackers a couple years before he came in, and it kind of led to this just horrible fear of any sort of choking from anything, and he wasn't able to eat anything. I would talk about food, and he would start dry heaving, and so that was a really great case to use it in. I had another patient who had muscular dystrophy, and he was kind of in the later stages of it and just really wasn't physically capable of eating enough to maintain his weight. And so we actually were able to place a surgical G-tube in this place because we knew that, as he neared the end of this whole situation, he would need to kind of use it to keep up his nutrition. It can be used for patients on an extremely high calorie level, so sometimes 4,000 calories or more to help alleviate discomfort. And that's okay sometimes, to know that it's just going to be supplemental for our patients is appropriate. Again, this can be a barrier to discharge, and so really helping them to find a treatment center that can handle nutrition support can be really important. If they're hypoglycemic, like I touched on earlier, this is the preferred method to deal with that. So they kind of get that consistent combination of protein, carbohydrates, and fats. So placing a feeding tube to help with the hypoglycemia and help to regulate their blood sugar can be really helpful. Like I said a couple slides ago, if they have SMA or severe gastroparesis, this can be helpful. And then also reminding them that it can be supplemental. I think sometimes patients have a hard time making this choice because they think, am I going to only be on the tube now? Is it going to delay my discharge? Do I have to have it all day and eat all day? So really helping them to remember that they can have it overnight if they want and eat during the day, and we can keep adjusting it as we need to, I think can be really helpful for them. So you can use a nasogastric tube. We use Dubhoff tubes here, which is kind of, I think, just the brand that we use, but this would be like a weighted feeding tube with a little weight on the tip that helps to guide the tube kind of through their stomach, hopefully down in their duodenum. This can be really helpful for our patients with the feelings of fullness that they tend to experience. And so that's what we prefer to do. In really serious cases, we can use, surgically placed tubes in their jejunum or in their stomach. I would just urge anyone who's considering this to make sure all other options are exhausted, especially if they're really malnourished. Patients, sometimes think this is just an easy way out. We've had patients come in here that are able to eat without any problems, but convince someone to give them a feeding tube and then refuse to eat because they have this tube. And so I think really making sure that it's actually appropriate is really, really important. I had a patient come in not eating a single calorie because she had a surgically placed tube and she was so dependent on it. And by the time she left, she was eating 4,000 oral calories and didn't need this tube anymore, but convincing them to let go of that can be like a huge psychological battle. But if it is indicated that it's going to be long-term, they do have swallowing difficulties or they just can't get the nutrition in for whatever reason it is, like the muscular dystrophy kids that I had, those would be good indications to use a surgically placed tube. So we recommend starting with a no-fiber formula if the patient hasn't eaten in a while. Going back to the whole gastroparesis issue, if they're on a higher fiber formula, it is going to cause more fullness and discomfort with the tube feed. So, low fiber or no fiber formula is going to be an appropriate thing to start with. If they're tolerating it really well, advancing them to a more calorie-dense formula can be appropriate. So, if they're being fed into their jejunum, at some point you have to be aware of the volume of tube feed. So if you're getting up to those aspirin recommendations of 150 to 180 mils an hour, you really need to kind of take sight of what formula they're on. Could you change them to a 2 cal or a 1.5 cal or a 1.8 cal per milliliter formula and really reduce that volume for them? Can you just get them to nocturnal tube feeds by reducing that volume? So again, if they're tolerating everything okay, kind of switching to that can be really helpful. Weighing the pros and cons of nocturnal versus continuous tube feeds. So Is their blood sugar low? Are they eating? If they are eating during the day, nocturnal tube feed is a great option. If they're refusing to eat during the day, we don't want to set this precedent that it's okay to just get nutrition overnight while you're sleeping and never have to think about it. So taking that into consideration, if they do have low blood sugar, sometimes they're eating and they're getting tube feed to really combat that hypoglycemia. Adjusting the tube feed based off of patient schedule or completion. This is a slippery slope with this. We'll use sometimes their tube feed to supplement what they don't eat during the day. So if they don't complete 100% of their meals, the remaining calories go into their tube feed, but can be confusing for the nursing staff and challenging with the patient. They are so aware of every calorie they take in that they didn't eat 3 bites of their peanut butter and jelly sandwich. They've calculated that to exactly 87 calories. So when the nurse adjusts the rate, it turns into an argument. So that can be a tough road to go down. Weaning off of enteral nutrition and adding oral nutrition. When is this appropriate? So, I just had a patient leave who stayed on 100% enteral nutrition the entire time he was here. He voiced daily and advocated daily to stay off of oral nutrition because he was just too anxious. And we talked all the time about the pros and cons of adding it. And as a team, between the psychologist, the doctor, myself, and the patient, we decided this just wasn't the appropriate place for him to start oral calories. When they do feel ready, we can really help them make some calorie-dense choices to start increasing more oral nutrition in their diet and kind of wean them off hour by hour if that's what's the best option. Have they been cleared by speech? Did they get this tube put in because they had swallowing difficulties? So making sure they're safe to eat and swallow. And then also kind of going back again to their discharge plan, where are they going from here? Are they going a patient that only takes nocturnal tube feeds, or are they going somewhere that takes 100% tube feeds? So really helping them to meet those goals to make sure their discharge is actually an option for them. Parenteral nutrition is something else we can do here if we really need to. You'll probably ask any dietitian how they feel about it, and they'll say they only want to use it if it's absolutely mandatory. So same goes for the dietitians here. There is a high risk of complications. So of course, oral nutrition is always the preferred method of refeeding. If your stomach works, we want to use your stomach. If your gut works, we want to use your entire gut because it gets lazy. And so we really want to make sure we're reminding your body what it's supposed to be doing. It should be used for severe cases only when the patient's unable to tolerate oral or enteral nutrition for some reason. And then obviously utilizing your dietitians to really make sure they're there to help with the appropriate calculations and monitoring of the PPN or CPN. Typically not indicated because there is a high risk for infection for any patient. And so when you're malnourished, that risk for infection is going to go up. Your immune system is more compromised. You don't have as much energy and strength to fight things off. And so, again, in this malnourished state, we only want to use it if it's absolutely necessary. It can be used for patients with obstructions or other reasons that may indicate bowel rest. So CPN is ideal to PPN because it can give the patient more nutrition. So if a patient does need 3,000 calories, we can do that with CPN and not with PPN. So assessing for that. But you never want to use it and just say, the patient doesn't want to eat, the patient's freaked out, let's do this. That's when you really have to come together as a team and say, how are we going to convince them to eat or take in a feeding tube? Because PPN or TPN is just not indicated at this time. You still need to be aware of their glucose and lipid infusion rates. And so this can be really tough with this population because when you're using their actual body weight to calculate their glucose infusion rate, it can be really hard to keep it under 7, which is what ASPEN recommends. But if you use their ideal body weight, it's a bit easier. And so kind of weighing the pros and cons of that and really monitoring their labs. If you give them a little bit higher of a glucose infusion rate, but their LFTs are okay, their blood sugars are normal, everything's going okay, obviously they're tolerating it. If their triglycerides are rising, their liver's getting enlarged, obviously they're not. And so really kind of taking sight of the reaction their body is having to those things. PPN can be used short term if you need it. So for instance, we had a patient who had to get surgery recently, and so she had to be MPO, so we kept her on PPN leading up to the surgery. They can use it if there's some sort of really severe trauma with enteral nutrition and they only need it for an acute situation, but it's only recommended for up to 14 days. So it's not something you want to do, for a long period of time. And we have found that we really max out around 13 or 1400 calories. So although it can be used, it's not going to do anything significant for our patients. On top of all of that, there aren't really any other treatment centers at this moment that can take people on CPN or PPN, and so depending on their discharge, again, it can be tough to start that if there's really no end to it. So I think I have a couple minutes to go through these case studies really quick to just kind of give a brief kind of information on a couple patients that I've worked with that have had a couple of these things going on. So both of these patients have been on feeding tubes. They're both patients that came in severely malnourished, at risk for refeeding syndrome with gastroparesis, and so just kind of a combination of issues that we discussed during this talk. So the first patient is Sarah. She was a 40-year-old female, and she had a past medical history of traumatic brain injury combined with right eye blindness. She had AMBP, a mood disorder, and an anxiety disorder. She came to ACUTE from an external treatment center for treatment of severe malnutrition, medical stabilization, and weight restoration. When she admitted, she had an NG2. She had been put on a certification and mandated to treatment, and she was admitted to us emergently for hypophosphatemia secondary to refeeding syndrome. She could not lift her head off the pillow or open her eyes when she came in because she was so weak and malnourished. She was 5'7". She came in at 34.4 kilograms, so 56% of her ideal body weight, and her BMI was 11.9. Her FOS was 1 when she got here. Her MAG was 2.3, and her BUN was 29. She was started on Reglan, a multivitamin, Fosnac, thiamine, and aldactone. The aldactone was to help with the anticipated edema from the purging. She was on tube feed while she was here, and she used both our no fiber formula, Osmolite, and our 2-cal. She did not indicate that she had an eating disorder. She said she had a traumatic brain injury that caused her to spend a lot of time in a rehab center. Due to all of the rehab work she was doing, she said she lost a lot of weight. She said she was vomiting, but it was because of her brain injury, not because she had any body image issues. She didn't receive any formal treatment prior to coming. She reported an aversion to most foods and having no desire to eat anything. She did have a huge history of physical activity. She actually did some amateur legs in the Tour de France. She was always doing triathlons, hiking, and so she was being incredibly active for the lack of nutrition she was taking in. Her family felt like she had an eating disorder, and her diagnosis fluctuated the entire time she was here, from ARFID to AMBP to ANR. So I think officially she was diagnosed with an eating disorder, but it did take a while to get there. We started around 1,800 calories. She at one point was on 3,800 calories, and orally she only ever ended up taking 450 calories. She really had this kind of aversion to food the entire length of her stay. It was a real big struggle to get her to eat, and it just really felt like torture to try and convince her to eat something. We weaned her off of the tube feed a little bit. She started with 150 calorie snack once a day and ultimately was doing 3 of those a day. She never got past 450 oral calories while she was here, but she was getting her tube feed just during the day so that she could kind of be off of it during the night. She stayed here for 51 days and went to a res program from us. She continued to weight restore and work on increasing her oral calories. She gained 14.7 kilograms during her stay. She left to 80% of her ideal body weight with a BMI of 16.9. And she was such a unique case because she, really struggled with the oral intake. She struggled with the gastroparesis. She had to be on tube feeds. She ended up getting a surgical tube while she was here. And then when she came back, she, had her tube taken out at Denver Health because she was staying locally at a treatment center. And we've heard from her since, and she's in full recovery. She's hiking through the Himalayas right now at a really healthy weight, eating everything. And so the following treatment center, she went to did an excellent job of helping her with that. The next patient was definitely ANBP. She made no doubts about that during her stay. She was a 20-year-old female, and we'll call her Brittany. She had anxiety, depression, and OCD. She actually came to us twice. She came the first time via an air ambulance, and the second time she came from an external treatment center due to behavior she was using upon discharge from here and admitting there. She was admitted for anorexia, binge purge subtype. She was 5'6" and 29.3 kilograms when she came in. She was 50% of her ideal body weight. She also was pretty unable to have a conversation for about the first week she was here. She doesn't really remember being here because of her malnutrition, and it was a struggle to get her to eat anything. She started on 1,400 calories, 100% via Enteral nutrition. She had a huge history of purging. She was throwing up every single thing that she ate. She did it a couple times while she was here when she was mad at people. So we felt like enteral nutrition was the best way to immediately nourish her. She was eventually on 4,000 calories and discharged on 3,500 calories. Prior to arrival, she was only eating soup. So this was lettuce. She was eating lettuce, and then her soup was garlic and water that she was heating up. We slowly started to work her off of her enteral nutrition 1 hour at a time. So we started with safe foods like lettuce that has really no nutritional value, but it gave her some comfort, and slowly introduced some fear foods. By the time she left, she was eating every single food on our menu. She was eating 4,000 calories and was using 0% of her tube feed. Upon her final discharge, she was on 3,500 calories. She was here for a long time, 97 days, which is much longer than our average length of stay. She discharged at 52.2 kilograms, so she did gain 22.9 kilograms in-house, and she was 88% of her ideal body weight with a BMI of 18.5. She did go on to receive further treatment from us, and I have not heard what happened from there. And those are my final 2 case studies. So does anybody have any questions? I probably have about 5 minutes to answer questions.
Hey, Megan, it's Melissa. There were actually a few questions that popped up while you were talking. So we'll try to get through a couple of them, and you can just call it quits when you're out of time, and I'll have people email me if necessary.
Okay.
So the first one is, can you please give some examples / cases that exemplify how you work with a patient to compromise?
So the question was to work with a patient to compromise. So let me think about this. So I just had a patient who was here, and she came in vegetarian and completely unwilling to eat really anything outside of her comfort zone. So when she first came in, I let her eat 100% what she was comfortable with while she was still meeting her calorie goals. And then from there, we kind of started talking about adding more foods into her diet. And so I made a list of foods on our menu and told her that she could pick whatever food she wanted from that list, but every day she had to add a new food into her diet. And the patient responded really well to that because it was a slow introduction of different things, and she could kind of assess her fear level and what she was willing to work towards. I think another example is working with a patient that's vegan. That can be a big challenge because they might say when they come in, I'm really willing to be vegetarian when I get there, but they get here and then they're like, absolutely not, I'm not being vegetarian. So, allowing them to kind of say, okay, we're going to start with bread, and there's maybe some honey in our bread that's not vegan, and then from there we're going to do an egg, or we're going to do a piece of cheese, or we're going to do a mayonnaise that has eggs in it. And so again, kind of starting slow and not saying, too bad today you're drinking a cup of cow's milk, I think has been another helpful situation.
Yeah, and just kind of to add to that, Megan, I get so many questions about the nutrition piece of ACUTE when I'm out there meeting with partner programs and providers. And I think that's one of the most beautiful things about our program is the fact that we're not, a group setting. Everyone gets complete one-on-one time with you. And so you're able to really plan around kind of their needs and their phobias and work with them on all of those kind of things versus kind of more of like a milieu setting.
Yeah, and I think it's helpful because there's no comparison either. You're not looking at what someone else is eating, so that can be helpful.
Yeah, no, absolutely. I think that's a great point too. So the next question is it possible for a patient to have gastroparesis if they are 95% of their SBW, or that means that they could, or does that mean that their SBW could be wrong? How long could they have those symptoms once refed?
I've never heard the term SBW before.
I'm assuming she means IBW now that I'm looking at it, but it does say SBW.
Okay. So the question was just, could they have those symptoms at 95%? Yes, they could have those symptoms at 95% because it's typically caused by weight loss. So if they were, 120 and 130% of their ideal body weight, and they lost, I think it starts at 10% of their weight or something like that, they can have symptoms of gastroparesis for sure. And then what was the second part of the question?
Like, how long could those symptoms continue even after they've been refed?
I don't know if there is an actual answer to that, so that might be a better question for a doctor, but for our patients, at least, they experience symptoms of gastroparesis, and it could be the whole time they're here, and it could be something they really unfortunately experience for the rest of their life. There's really no cure for gastroparesis. There's just treatment for it, from my understanding, and so the symptoms can alleviate and get better, but they still might experience some of that early satiety and fullness.
Wonderful. Thanks, Meghan. Okay, the next question is, how do you address their resistance? What if they refuse? Do any patients ever leave? I think you kind of touched on this during your talk, but if you want to.
We address the resistance by taking a team approach. So first, I would definitely ask them, why are you so resistant to this? Is this something we can kind of work towards together? Is it a control thing or is it a fear thing? And then ultimately, I think what we will do at least is go in with a doctor, a psychologist, and a dietitian and kind of talk to the patient about why they need nutrition. If their resistance is just, I'm not going to eat dessert the whole time I'm here, okay, fine. But if their resistance is, I'm just not going to eat the whole time I'm here, it's obviously a much bigger issue. And if we can kind of identify that they're, not eating and not taking nutrition or using inappropriate behaviors, and that's making them more medically compromised, and that's when we would kind of decide if we were going to move forward with some form of involuntary treatment. But that's a much bigger decision than just the dietitian for sure.
Next question is, do you have to get another x-ray of the fat pad in order to resume diet to general or discontinue tube feeding? I'm assuming this has to do if complete SMA. She followed it up with a second question. Yep.
Yeah, so no, I don't think we ever do, I guess I shouldn't quote me on that, but we typically don't do a second scan. I think Dr. Mailer says, this can resolve within 5 pounds. And so not for every case, but it's really, just advancing them is tolerated. So if they've gained 5, 6, 7 pounds and you want to start them on liquids, or if they're already on liquids, you want to try some soft solids, you really would just kind of listen to how they tolerated it. If they ate those soft solids or those pureed foods and they were still in extreme pain, then the next step would be, okay, we're going to go back and have you gain a few more pounds. But if they've gained, 10 or 15 pounds and they're still having that, then yeah, I would recommend doing further studies to see what's going on.
Perfect. All right. Then we had a couple questions that kind of ended up answering themselves, so I won't go through those. How do you handle hypoglycemia that is triggered by eating?
I think that's typically when the tube feed would be, the most appropriate option, because obviously sometimes that does happen, the reactive hypoglycemia. So really trying to, explain to them that this kind of persistent nutrition with the tube feed is what's going to regulate your blood sugar until you can store more glycogen in your liver is going to be, I think, the best way to handle that.
Wonderful. Okay. For outpatient, do you have recommendations regarding monitoring thiamine and zinc levels? If low, what dose do you use for each?
I will have to defer to a doctor on that question. I don't know the doses they use.
Okay, no worries. Lisa, if you can just email Melissa Chura, I'm on all of the emails for these webinars. I will do my best to get you an answer on that one. I'm not, this kind of isn't a whole question. So IBW is suggested for boy weight. I don't know if they're asking if we only use IBW for men, but we use it for men and women.
Yeah, we use it for men and women. Maybe, there's different ways to identify that. So, the way you would calculate that would be different. I think an important thing is to kind of focus on the IBW versus the BMI, because we do see men's BMI tends to be a lot higher than reflected what their ideal body weight is. So not using their BMI as kind of a status of where they're at can be helpful too. I'm not sure if that answered the question, but that's some information.
I'm not totally sure what the question was. So, and she's left the room, so she can't clarify for us. So, okay. Do you have guidelines to keep CHO at above 40% of the energy intake?
No, so we really monitor their LFTs while they're here. So again, this might be different in a different setting, but going back to kind of our main philosophy is just nutrition. We really just want to make sure that everything's okay. So, or they're getting their nutrition. So if they're like on a really low, if they're on a lower carb diet, like say they're getting 35%, it's not something we're really going to push as long as everything's going okay, their blood sugar is okay. And on the flip side of that, you know, if they're getting 50 or 60% of their diet from carbs and then their LFTs are starting to rise and they're getting some form of hepatitis, then we need to make sure we're reducing their carbohydrate content. But no, we don't have specific guidelines as long as everything's going okay.
All right. What route of feeding do you typically use to manage SMA?
I'm trying to think. I've had one patient who actually ended up getting the SMA surgery because nothing else was working, and he got a surgical J tube placed. But otherwise, I think every other patient I've had, we've been able to use liquids to do it. Even in the more severe cases, we've been able to use liquids to help them gain the weight back. And if the patient prefers, because the liquids are just not fun, we can typically still drop a Dobhoff tube and feed them kind of into their duodenum before the SMA, but the liquids will still pass through from the tube feed.
What is the expected goal for weight restoration at ACUTE?
I think it really just varies on the patient, you know, how much progress they need to make and what the patient's willingness to do is. So some patients are willing to go a little more quickly, other patients want to be a little more conservative. So it can really be, I think, anywhere from like 3 to 4 pounds a week, depending on the patient.
Do you have any guidelines that could be presented to emergency departments to avoid bolus IVs?
Dr. Mailer's book does. I think it's, hold on, I highlighted that the other day. I think it says restore volume with IV normal saline slowly, so 50 to 70 milliliters per hour. And then Rachel said that there's also an article she can send out to people that are interested in that as well.
Perfect. And also, Dr. Mailer is doing presentations to emergency room departments on this very topic of how to identify eating disorders and how to treat them and how to get them to the proper level of care. So if any of you guys have good relationships with ERs and would like to connect me to get one of those presentations set up, I would be happy to do that. Moving on to the next question. What do you do if a patient reports involuntary vomiting when eating or drinking liquids?
Well, unfortunately, that's something we deal with kind of often. You know, I think we just kind of use our nursing assistants to really help us out with that. So that's one great thing. One of the great things I think about being here is they do have one-to-one supervision, and these patients are savvy and purgers are good at purging without, you know, using anything other than just throwing up. But usually, you know, our nursing assistants can report, you know, they actually like, it always happens 20 minutes after their meal, and they are always kind of really leaning over or pushing on their stomach or retching or whatever it may be. So we can usually identify that pretty quickly. And if they're saying that it's involuntarily, then we usually just have more reason to say, okay, well, if it's involuntary, then you're just kind of showing us that your body can't, you know, be given control right now, and we're going to use a feeding tube to kind of hopefully feed you even into your jejunum to really reduce the risk if we need to, you know, to help make sure you get all your nutrition in. And then the last time I used that, the patient revealed to me that he was bulimic, which, you know, I was already aware of, but he felt like it was this really big revelation and promised he wouldn't do it anymore if I just didn't put the feeding tube in. So sometimes just the unfortunate threat of a feeding tube can make them stop, but you know, if it really is involuntary, then the feeding tube can be an appropriate tool to utilize.
Let me tell you the next one. This one says the tech placed an NG tube, but poked her tube into her nose up to her head, so she felt it. And they're due to the thinking. Is that possible? Or do you think it would be SMA side effects? Is there any concern for a weight gain greater than 5 to 6 pounds a week? I've heard some MD do it, but not sort of research.
So the question that I just was asked was if there's any concern for weight gain greater than 5 to 6 pounds a week. I think my concern with that would more be psychological than anything else. I'm not sure if there's a bunch of research on that or not, but I would think it would be really challenging for a patient to gain 6 pounds a week, just to kind of physically feel all the changes. And then on top of that, the amount of nutrition I think they would need to be taking in would be incredibly uncomfortable as well. And I think that was the last question. Thank you guys so much for listening. And if you have any other questions, please feel free to email Melissa, and I'm happy to answer those over email. Have a great day.